I was going to quickly give a short overview of the primary palliative care reference group, what we do, who's involved, and our aims. And because this is one of our outreach activities, and we're really keen to get people involved in the work that we're currently doing. And we have the executive committee, but also we have a greater group of members, which we're well over 100 members, and we'd really be keen for other people to get involved if you're working in this space or just interested in this space. So as you can see, the primary care reference group is one of the reference groups of the EAPC, and it's been in existence for, well, I think we're almost coming up to 10 years. The focus of the reference group is looking at how primary palliative care services can look to meet the increasing challenges that we'll all come into contact with in the coming years, with a greater group of people who have palliative care needs, but of course increasing challenges in terms of healthcare resource usage and also availability of healthcare providers. And we see that primary palliative care is ideally placed to meet the needs of the future, the future healthcare needs of the population. And we think it's very important that we try and advocate for primary palliative care internationally and on national scale. We have an executive committee with representatives from many European countries and some international members, as you can see, and our main aims focus on advocating, facilitating training and education, also networking with other member organisations, professional organisations in primary palliative care, such as WONCA and other organisations in palliative care, such as the Asia Pacific, Africa and South American networks, supporting and develop research and identity mechanisms to support primary palliative care internationally, especially in low and middle income countries. Webinar is one of our core activities that we do, and we also have an open meeting at the EAPC Congress annually, and we also perform a number of other activities regarding focusing on developing research, of which this special edition was one of those activities, especially around looking at how primary palliative care can look at meeting those challenges for the future and defining how primary palliative care sits within different healthcare systems internationally. So I'm going to hand it over now to Tanya to describe about this special edition as one of the editors of it.
Yeah. Thank you very much, Matt. On my part, I want to warmly welcome to you to this webinar, and thank you for joining today. I already introduced myself. I'm Tanya Pastrana, co-chair of the reference group of primary care, together with Matt. And in this webinar, we aim to spotlight the special edition on primary palliative care of the Journal of Palliative Medicine. We want to highlight the key contributions from European researchers. I want to extend here my gratitude to Catherine Walsh for dedicating a special issue to this topic and to invite us to edit it. I would like to thank also Debbie Ashley and the editorial team at Palliative Medicine and the numerous peer reviewers and many authors who submitted their research to this special issue. It was really a fantastic experience. We will begin together today with an overview by Professor Scott Murray, and after that we will follow the individual presentations and a panel discussion with all speakers. Also, just a reminder, 2 weeks ago, we participated in a webinar organized by the African Palliative Care Association, APCA, and we have the opportunity to present articles relevant to the African context. But today, our focus shifts to Europe, and we invite the authors who will share today their experience, the evidence, the insight from the European perspective and from European research. I'm really particularly grateful to all the speakers who have so generously agreed to share their insights and to discuss with us their research. And I want to invite the participants to really engage directly with the authors and ask the questions and participate in the discussions and really make use of this webinar. Well, first, we can begin. So we have here the list of the participants, maybe an overview. And we will have Scott Murray, Emeritus Professor of Primary Palliative Care at the University of Edinburgh in Scotland. He is also the founder of the reference group for primary palliative care at the European Association for Palliative Care, as is because we exist. And I invite Professor Murray, please, to share our editorial. Please go ahead. Thank you.
Thank you very much, Tanya. Thanks so much, for that introduction. Can you hear me okay?
Perfect.
That's great. If you could share the first slide then, that would be great. So many thanks. I'm delighted to welcome over 100 enthusiasts from all over the world to this webinar today. It's great to see there's some old names and newer names as well, and it's great that we can start to see each other and understand and network. Tanya and I were the guest editors of this special issue in Palliative Medicine entitled Primary Palliative Care, which is a palliative care in primary care. We are delighted that palliative medicine actually turned its focus on this important topic, and we're amazed at the many dozens of articles submitted to us for consideration. We did a lot of reading, and we thank everyone who responded to the call. Some articles we didn't accept actually are published in other journals, such as the BMJ Palliative and Supported Care. So much work. Thanks everyone for that, just as Tanya said. Second slide, please. So Tanya and I wrote this editorial together and called it Primary Palliative Care, Onwards and Upwards. We've come onwards for the last 10, 20 years, but let's continue and go upwards in that trajectory. Palliative care in primary care. It's open access, most of the articles here, including a 4-minute summary podcast embedded in the end of the editorial. You see it if you actually go online. Palliative Medicine is palliative care journal with the highest impact factor and most read and cited in Pal Medicine. So that's why we're here. So we've arrived and we're advocating to generalists and specialists for palliative care in primary care. And we concluded in this, back to the slide, that palliative care continues to evolve and develop in the primary care setting to meet the outstanding challenge because it's being accessible and acceptable to everyone with life-threatening illnesses. That's the real challenge. Now, quality, I would think, is pretty good, but we have to spread. This special issue features a number of new studies highlighting the great potential to deliver palliative care in primary care. We have the potential. We define primary palliative care for this issue as palliative care carried out by primary care workers, including all professionals employed in health services and social care services, would probably include volunteers as well, who provide integrated healthcare for people in local communities throughout their life. Next, please. So this special edition highlights the great potential to deliver in primary care. There are 3 editorials, 3 review articles, as you see here, and then there are 6 original research. But let's look at first at the invited editorials. We're in the midst of the first one there. That's myself just now explaining that one. The second one is, as you can see there, Dan is going to be talking about that next, so I'll pass over that quickly. And the third one I point out is by Jose Pereira in Canada, where he maps primary and generalist palliative care in, if you want, in that neck of the world, which is a very useful editorial to look at as well later. And then in the next section, we have 3 review articles. The first is Primary Palliative Care in Low and Middle Income Countries, and that was presented a couple of weeks ago in the Africa Palliative Care Association. And that's a very interesting, looking at models, because models can be different. Should be based in primary care, but they are different according to what's happening on the ground at grassroots level. So have a look at that one. Electronic symptom monitoring. So there was another systematic review this time from China about that subject. which is interesting. And the third one is, how do primary care clinicians approach hospital admission decisions for people in the final year of life? So that one is from Europe, from Bristol there. Next slide, please. And I'll just give you that's what it looks like. How do primary care clinicians approach hospital admission decisions for people in the final year of life? Because possibly how can we avoid some unnecessary admissions looking back? Well, the implications were the findings of the review suggest more work is needed to consider how clinicians can work out with other stakeholders to reach consensus in decision making. You know, who do we talk to? Chatting to various people, carers, all the other people about when it comes to actually to admit or not to admit. Second point, resources and training could be improved to improve clinical confidence in end-of-life care and make complex decisions. So that's one that's, again, open access. Have a look at that one. Now we'll go on to the 6 original papers. Next slide, please. And you can see here, this is what the first one was shown to the Africa meeting quite recently. That was the evaluation of integrating palliative care in a refugee setting. And that one also has an EAPC blog with it as well. Fascinating. She used rapid appraisal consecutively to actually assess what was the problem and then to evaluate what had been done. Well worth a good read there. Next one is integration of primary care and palliative care services to improve quality. And that's Sarah Mitchell, who's now the clinical lead in the UK for a palliative medicine. So that's well worth reading as well, looking at models if you want that setting. Third one, looking at, this is Carlos's one, so I'm not going to say anything about it. We look forward to Carlos presenting that one soon. Excellent. The next one's about developing a palliative paramedical framework to standardize best practice. So this study from Australia, Josephine Clayton et al., are looking at integrating the palliative care approach in ambulance services, which is such a good and potentially beneficial area. Well worth the read. Next one is about caregivers of people with high their perceptions. It was never about me. So that's also well worth a read. And finally, the last one is factors influencing deprescribing, and I think we're going to have the pleasure of hearing Mikey on that one shortly. That one there talks more, maybe less, or less, maybe more, should I say. Less could maybe more at the end of life with respect to interventions such as hospital admission or over prescribing. Realistic. So that's a quick glance at those, and I'll just spend the next 5 minutes in actually just generalizing a bit. So this special edition, next slide, please. So where are we? Yeah, there. So these papers add to the body of evidence over 10, 20 years now that primary care workers supported by specialists and experienced generalists, because the experienced generalists is sometimes good at supporting us, can and actually do provide integrated palliative care for people with all diseases at all times, from diagnosis to birth, and can deal with all dimensions of need in all settings and all countries. That's a sort of signature slide I use to look at the scope of primary palliative care, because it can advance on all these fronts. Next slide, please. Primary care can also bring continuity of care. So I've got 5 C's here. It can bring continuity of care and compassion and communication and coordination skills to patients, adults and children and their carer. That's sort of how we do it. Next slide, please. So we were rather bold in our figures that we had in our editorial. We asked for 2 hands. So these 2 hands, as figures 1 and 2 of the editorial point out, that as well as the 5 Alls of the scope, we affirm that primary care can bring these aspects to bear. And I hope that you'll remember that what our hands can do in primary healthcare, and in fact the individual figures as well. These are the aspects, especially as a clinician, we can think and go forward in the scope and how we can do it. Next slide, please. And finally, we were invited to actually outline a framework to overview the potential scope of future primary palliative care research. So I've used the five alls, and let's then look. I'm suggesting what, on the basis of what we've seen, been done, what we've read, what's needed next. Now, the first one, we still need, we think, all diseases. We have to go beyond cancer. We've done that a bit, to frailty, and especially to people with multi-morbidity. And in my graphic, just to show you that one. So, because quite recent, next slide, please. We actually showed that we think that multi-morbidity has its own distinct trajectory towards the end of life. In some way, it's a composite of the three original ones, which are the blue, the red, organ failure, and the frailty. And multi-morbidity, in some ways, that patient actually has all these net effect, and we reckon that. And that multi-morbidity is a great area to be in, to do slides, so we can then give early palliative care. Because just like the arrow, you can see the arrow, that's when COVID came in and caused many people to die. We can see we ought to know the underlying problem. Next, please. We'll go back then to the framework. So next slide. First one is all diseases, all time. So identifying people earlier across all illness trajectories. This is what we need to do. Validating and maybe translating the palliative care indicators tools. Because it's the difficulty, the main barrier, I believe, honestly, for palliative care, and especially early palliative care, is to identify or to know when to actually bring up the subject of primary of palliative care, maybe not using those words. So I think we need more work to consolidate how that's been started, and we also need to balance slightly more nuanced outcomes, not just how many people got at the end of life, but when did it start, how did it compose. Next slide, please. I'm just going to illustrate that there was a tool called the Supportive and Palliative Care Indicator tool. Next slide, please. And it's now advanced to many, many countries. And all these countries now, we have partners of this tool, where there are people developing. In some lands, they've been translated into different languages. We have 12 different languages. This is the tool. And so there's been pilots happening in all these countries. Next, please. And in fact, the validation of the tool we did back 10 years ago, you can see, and each year it's really good to see that it's being cited more and more. And there've been hundreds, actually, more papers on SPIC. This is just a citations too, if you want the basic evaluation. So we need further work in actually extending it, whether it's the SPIC or other methods. We really actually know how we can start, because as soon as we can start identifying people, of course, we can start assessing their needs and planning their care and actually giving their care. Next, please. Nearly finishing. Next slide. And going back to the framework, so that was all times there, all dimensions. So we should test interventions to identify and address the dimensions which people find most troublesome. There was someone asking actually in the seminar to think about spiritual issues. Next, please. And the longitudinal approach can be quite helpful. So this is a slide from a while ago looking at the illness multi-dimensional trajectories, including the spiritual one of people with advanced cancer. And we can see at diagnosis, not only is someone maybe physically might not be bad, but then there may be issues with the spiritual distress or anxiety. Because someone was asking about specifically about could we cover that. So spiritual distress may be the main area, and we should always assess different dimensions and then try to help in that specific area, because even generalists can help in all these areas. Spiritual meaning existential issues that may be distressing. Next, please. So back to the framework, the last two thoughts with respect to the settings, to take a whole systems approach to describe how patients follow pathways across settings. So the idea, don't just look at one, if you want, dimension, but look at how the patient progresses through different settings and evaluates the whole thing in a public health way. Next slide. I think I've got a graphic to sort of show that. Yes, and here's showing, actually this is a picture of people accessing out-of-hours care in the UK, going from round the circle like this, phoning up and getting maybe a visit or an ambulance and going up for admissions. It's complicated. If you phone up in primary care, most people manage to stay there. But frequently people actually had to go to a hospital because there wasn't someone available in primary care. Next, please. just go on. So building on these large systems using large data can be helpful. So I mentioned about low cost, high value. That's what primary care can do. That's what we should be trying to do. Community development and volunteer innovations, also important to widen patients and the community understanding. So we should help primary care services, but also the aspects of public health in primary care, really important. And we can learn a lot from other nations about that. And finally, all nations, we need to do some research about cost effectiveness research, so to help just the governments realize, yes, we must do this. It's not really going to be too expensive. We need to develop models of care, building on existing primary care systems. We can't just put in something new. What's happening there? What's happening in this country? How can we build on that to integrate palliative care? Because some people say good primary care. Actually, palliative care is just good primary care, caring holistically for folk. And then testing models of palliative care to reduce these high-cost, low-impact treatments, unplanned hospital admissions, and disabling costs. Next slide, please. I think we're just about finished, yes. And just to say, there's a podcast at the end of this editorial to learn a little bit more about. But thanks for listening, and looking forward to getting some feedback and taking things forward afterwards. Thank you, and thanks, Tanya. Just handing back to you now, Tanya. Is that okay?
Yes, fine.
Then we'll get on with the next person. Thank you.
Yes, moment. I just want to share my next. I was waiting for Matt, but I have it, Matt. That's now. I will thank you, Scott, first for your overview. Fantastic as always, and it gives a very good idea about what we have to do as primary palliative care researcher. Well, and please join me to welcome Dr. Maaike van der Wal from Utrecht in the Netherlands, and thank you very much for being here, Matt.
Let me. Yeah. Thank you, Tanya, for the introduction. And next 10 minutes, I will discuss with you a summary of our study titled Factors Influencing Deprescribing in Primary Care for Those Towards the End of Life, a qualitative interview study with patients and healthcare practitioners, which was performed at the Center of Expertise in Palliative Care in Utrecht, the Netherlands. And now I'm already stuck. Oh, let me see. Yeah. 80% of all people die from cancer or a chronic disease. And this results in the prior use of many medications and polypharmacy in nearly half of the people aged 65 years old and older. So patients indicate that they would like to lower their medication use. And 1/3 of the people dying at home actually use preventative medications up until the day they die. And 73% of GPs recognize that palliative patients use too many potential inappropriately medications towards the end of life. And still, we see that deprescribing is poorly enacted in primary care. And this study aims, therefore, to describe factors as identified by primary care professionals and patients that influence deprescribing for those towards the end of life in primary care. For the methods, we did an exploratory study using semi-structured interviews, and patients, carers, and healthcare professionals in primary care, including general practices, hospices, and community palliative care teams, were purposely identified in the region of Utrecht, the Netherlands. Interviews were audio recorded and manually transcribed verbatim. An inductive thematic analysis was applied. Data saturation was required for major lines of inquiry based on an expert consensus topic list. And data saturation occurred after 17 interviews, of which 5 were with patients or carers. The results, so 3 main themes were identified from the interview data, showing some overlap, and I will discuss them in the following slides. The first main theme was non-maleficence, the importance highlighted by both HCPs and patients to prevent unnecessary additional mental and physical distress. So with the sub-themes end-of-life communication and high-risk perception. And end-of-life communication is more about the mental harms. And we saw that this study confirmed that patients are open to discuss deprescribing, and especially when they have a trusted treatment relationship with their HCP. And ironically, it's this trust that HCPs do not want to betray, by example, by misjudging life expectancy. So this makes it a hard topic to discuss. And the second subteam is high-risk perception. HCPs experience there's a lack of guidelines and information, and therefore fear to deprive patients from optimal care. And in addition, there's a strong association of medication with clinical stability. So both patients and HCPs feel that medication helps people stay on their feet longer. And that's indicated by the quote of a patient. So it makes me feel safe, but I wish I could do without all that mess. And this association was the perception of risk was even strengthened by negative experiences. For example, if somebody developed a CVA upon stopping anticoagulants. The second main theme was reactive care. So despite the recognition of its importance, deprescribing is still a very reactive process, with two subthemes identified. So a lack of priority of deprescribing, which is related to the minimal harms of continuing potentially inappropriate medications, the perception of minimal harms, and also the perception of minimal costs. So a medication review will, oh, I see the slide's not really nice, but so a medication review will only be done if there's a urgency in clinical complaints. And the cost argument also doesn't resonate in primary care, although studies have shown that due to a high number of patients, the impact can be still considerable. And another factor for reactivity in the deprescribing process is the limited recognition of patients who can be eligible. So medication reviews are often instigated by pharmacists who pre-select patients to discuss with GPs. And the selection criteria are based on polypharmacy and age, but not on life expectancy. And people eligible for deprescribing are often the elderly or chronically ill, and they are seen by nurses who have a limited role in these medication reviews. So we see there's a misalignment in roles and responsibilities there. And both patients and healthcare practitioners are they both indicated that raising awareness for potentially inappropriate medication could effectively be initiated by patients themselves. So patients requesting medication reductions were said to be more likely to have their medication reviewed and subsequently stopped. And that's illustrated by this quote of a patient who indicates that the statins were stopped because he indicated that it was bothering him. And he also said that to have become more assertive over the years in the communication with doctors. So the third main theme was discontinuity of care. And that's within primary care and between specialist and primary care generalist. So within primary care, having a deprescribing process in place with time and staff allocated for medication reviews and follow-up was thought to greatly facilitate the deprescribing process. And reviews were often done by GPs, while the follow-up was allocated with nurses with limited communication on the decisional motives. And also, alignment on communication to patients was essential to prevent insecurity with patients on the appropriateness of deprescribing. The second subteam was that deprescribing of medication was considered the responsibility of the GP, so in primary care, supported by nurses and pharmacists, but many patients towards the end of life have a specialist doctor in the hospital, and primary care practitioners were reluctant to interfere with specialist-initiated pharmacotherapy as they felt less comfortable, less capable of appreciating the risks and benefits of specialized medications. And in addition, we saw interference of deprescribing by acute hospitalizations, like this quote illustrates, that somebody who was in the hospice broke her hip after myocardial infarction and returned from the hospital with an awful lot of medication. So new things started in the hospice, statins, metoprolol, everything. Yeah, cardiology guidelines. It brings us already to the conclusion that deprescribing is an incremental de-implementation process influenced by the following factors. So uncertainty about life expectancy, association of medication with clinical stability, and the possible impact of pervasive asymmetry, which is a concept from psychology that comprises that stopping an ineffective care is actually harder than starting something new and promising. And the fear to lose something is often larger than the appreciation of a possible gain. And to support deprescribing in palliative care, there is a need for proactive and multidisciplinary patient identification. We heard about that before. So alignment between GP, pharmacists, nurses, and roles and responsibility, with possibly a more prominent role for the nurses in this. And normalization is something that can support deprescribing. So positive framing, and never say you will use this medication for the rest of your life. And shared decision making, including empowering patients to start a deprescribing conversation. And last but not least, which is always important, so support from guidelines and education of ACPs, in which we think they're giving more awareness for existing guidelines is most important. So I herewith thank you for your attention. I hope I didn't speak too fast, and I'm happy to take any questions.
Yes, thank you very much, Maike, for the excellent presentation, also for very interesting research. And your topic, I think that is a very, 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 for us in our department, very important topic. And I'm very, very curious about the questions that you will have, because, yeah, we should get in deep with that. And you can think about how can we do for get better in this field. Well, thank you again. And we will move to Portugal, and this is a pleasure to introduce you our next speaker, Dr. Carlos Seiza Cardoso. He is professor at the Faculty of Medicine at the moment, as I have the slides, the corresponding slide, and the University of Coimbra, well, there in Portugal. And well, Carlos, he has another topic that can combine my idea with Mike's topic. Please, Carlos, go ahead. Thank you.
Thank you, Tanya. I'm just trying to share the screen. This one. Can you see the presentation?
It's it's not the presentation mode. It's not the large view. You can.
How did you fix that?
If you is down, you can put down. If you want, I can share your slides. I have your slide.
I think it's better because I don't know how to fix this. Yeah.
Okay. Can you see that?
Yeah.
Okay.
Perfect. And thank you all for taking a little of your time to discuss and share your thoughts about this topic of primary palliative care. I'm here to present you this paper published recently in this special issue of Palliative Medicine titled Feasibility and Effectiveness of a Desired Complex Intervention Involving Both Training and a New Consultation Model for Patients with Palliative Care Needs in Primary Care, in Portuguese primary care setting. Next slide, please. Yeah, the world population is aging, as we all know, and even if we want to, we cannot escape for this reality. The prevalence of chronic diseases is increasing, And so the prevalence of chronic diseases, progressive and end-stage chronic diseases will also increase. So we really need to talk about palliative care. But the point is, why should we talk about primary palliative care? Next slide, please. We have some data from research that say that on one hand, some of these diagnoses of people with these chronic illnesses is made in primary care, and people is really managed in first stage of their diseases in primary care for long periods. But also we have some data showing that when the GP or the family physician is involved in the provision of palliative care, it seems to improve, both with benefits for patients and their families. So this is our question. Should we proceed with research in primary palliative care? Next slide, please. And that leads us here. We developed a before-after study involving both GPs or family physicians in Portuguese setting and patients with palliative care needs, adult ones, from their list of patients. And we try to think about this. Can we develop an intervention that can be useful, feasible, and effective, both in improving symptoms of patients with palliative care needs? We tried to recruit both family physicians and 53 patients from their list of patients. Next slide, please. And how did we build our complex intervention? We thought about training, because we have some data referring that family physicians and general practitioners need train about palliative care. And we used a previously published paper. We ran a double focus group with family physicians, both trainees and specialists in Portugal, asking them how do they see their role in the palliative care network, in the Portuguese one, if they have training needs, and how would they imagine the best training program they can figure to fill gaps they felt about palliative care delivery for their patients. And we tried to develop this training program with help, and I need to really thank the study group of palliative care from the Portuguese Association of General Practitioners that help us with this training program and also to deliver training to the physicians we recruited. As to the new model, the new consultation, we have consultations every day. We manage people with palliative care needs every day, even if we don't call them people with palliative care needs. So what we thought was, can we try to get some model of consultation that we can deliver to patients with palliative care needs, and all the GPs, family physicians, can deliver the same type of consultation for these patients. We ran and searched for the literature. We found some guidelines. We researched also the WONCA recommendations, and we developed this consultation model, which is not that different from a family physician's Portuguese consultation from our daily practice. Next slide, please. Okay, so we wanted to recruit family physicians. We recruited physicians from Central Healthcare Region of Portugal, and we asked them to recruit patients from their list of patients with metastatic neoplasm and also COPD, congestive heart failure, and chronic kidney disease. And we asked them to search those patients and find those who have end-stage disease or at least advanced stage disease. And these would be the ones that they should recruit to this intervention. Next slide. Okay. We define our primary outcome related with the impact on physical symptoms, but also two secondary outcomes related with emotional symptoms and communication practical issues. We use the IPOS patient version, which is already translated and validated for Portuguese setting. And that's how we evaluate the effectiveness of our intervention, using IPOS in the time 0 and after the intervention. The intervention was the application of this consultation model 3 to 3 weeks for 3 months. So each patient would be managed for his family physician for 3 months. And after that, we asked each patient to fill the iPulse patient version again. Next slide, please. Okay. We recruit 10 GPs that finished the training program. Then we have one dropout, one GP could not proceed, but the 9 that left just recruit the 53 patients, both with advanced neoplasm, chronic kidney disease, congestive heart failure, and COPD. We have some dropouts, but 36 patients finished the 3-month intervention. After that, we could only evaluate data from 35 patients because one of the questionnaires was not, we were not able to read. It was not well written. So we evaluate data from 35 patients, and I would like to present you the results of this intervention. Okay. About the 35 patients for analysis, we have a mean age of almost 72 years, almost even female and male participants, and the main diagnosis groups was advanced neoplasm and congestive heart failure. But we get some patients with chronic kidney disease and COPD also. Next one. And this is the spotlight. After a 3-month consultation, after the training program for these GPs and applying these 4 consultations for 3 months, we get some statistical significant reduction in our primary outcome, physical symptoms burden, with a medium effect size, which is not very typical in palliative care, in studies with patients with palliative care needs, but also in emotional symptoms burden, also with significant reduction. We missed the reduction about communication practical issues, but we managed to conclude and to succeed with our primary outcome. We have reduction in physical symptoms burden for these patients. Next slide, please. This is we can see the evolution for all the 3 outcomes for every patient. And those squares painted in green are those related to patients who experienced some improve in at least one of the dimensions. We can see that almost all patients experience at least improve in one of our outcomes, but the one we get with more strength results was physical symptoms burden. Next one, please. Okay, we achieved our calculated sample size. Our attrition rate was well calculated because this was exactly what we get, and we were very enthusiastic with our effect sizes. Of course, this is a before-after study. We lack a control group. We had some heterogeneity, and of course, we may have some selection bias because we expect that the physicians that we could recruit may have already some interest in the topic. But the spotlight is we have a reduction with a medium effect size in symptoms burden of patients with palliative care needs managed by their family physicians in primary care. And I think this is a very important result. Next slide, please. So our intervention showed to be feasible in primary care, at least in primary care setting, and may be effective, reducing the physical and emotional symptoms of these patients. Next slide. I would like to share you these 2 conclusions that seems to be very important, at least for me and for the team working this. We can have some primary palliative care research implications, but also primary palliative care practice implications. Next slide. Well, we have preliminary data on attrition rates, effect sizes, and sample size calculation for different outcomes in primary palliative care interventions. And we also showed this new intervention, this complex intervention that showed to be feasible and may involve family physicians from primary care settings and involve their patients, list of patients from this family physicians, and we can really improve at least these outcomes. Next slide, please. But also some primary palliative care practice. I'm a lecturer in Faculty of Medicine, University of Coimbra, and since last year we start this new cathedra, this new palliative care cathedra, and one of the major lines is related with primary palliative care. With this help of Floriani Foundation, we could already reproduce this training program, and almost 50 family physicians receive this training and receive information about this new consultation model. So I think more or less 50 new family physicians can start make this different from their list of patients with palliative care needs. Next slide, please. And I think this is the major implication, the umbrella that primary palliative care can be for every patient, so that this palliative care philosophy can reach everyone. Thank you so much.
Thank you so much, Carlos, for the presentation. Really interesting, and probably have some things to discuss, especially because Matt have some also research about the research in primary palliative care. Maybe interesting to discuss this later. And it is now moment I have to change some presentations. Now. Yes, now, last but not least, it's an honor to have Dan Monday with us. He will present the editorial that we have the pleasure to co-write, co-edit together with Scott. Also, Dan. You're welcome to share if you want.
I'm sharing.
Okay.
Hang on a minute. We did this before and it worked, and this time
It's worked just once.
Right.
In the meantime, we can reflect a little bit on the both empirical, original research, and have some ideas what can we discuss with the authors of this research, maybe for your own idea, your own research, your own setting. Like how can these findings be applied maybe in your environment or not? And if you have problems, then I can share for you if you want.
Have you got my presentation?
No. I have your presentation, but not the final.
Oh, no. I'm sorry.
Sorry, my image.
Oh, is it coming?
Do you want to send it to us, Dan? And maybe we could start engaging in a bit of a discussion while we're waiting for it. So, yeah. And while we're just waiting, I was interested, Carlos, with your presentation, did you also look at the impacts of this intervention on healthcare providers as well? And yeah, be really interested in what you found.
Yeah, we have collected two different outcomes. One related with satisfaction, feasibility, replication, and thoughts about of the family physicians involved, and another one about healthcare resources. If these patients manage for this 3 months, started to go less time to ER, to acute consultation, internships in the hospital. Regarding your question, almost 100% of the family physicians were very enthusiastic because they were almost surprised with the results. They didn't think that this small intervention could have this implication. And this was not difficult for them to manage in their list of patients. Of course, we have some patients that were stable, and they may not need this 3 to 3 weeks consultation. So we are trying to scale up this study design, and probably we'll need to fix this intervention, maybe involve some phone calls, consultation in patients that are stable, but almost 100% of the physicians really keeps doing this consultation with these patients and other ones, because we manage some different way to identify patients with palliative care needs, so that they can, using the codifications of these chronic diseases, they could identify patients in their list of patients and start replicating this intervention. This was a very funny part of the...
Wow, fantastic results. So we might, I think it'd be great to discuss more about it in a minute after Dan's presentation, but we might, now that the sharing's working, go to Dan.
Yeah.
Thank you.
Yeah, sorry about that. I think it was just taking a while to load. Good afternoon, good evening, everyone, wherever you are, and thank you for the opportunity to present this. We're going to focus a little bit more on low middle income countries and the importance of primary palliative care, but it's just so great to have two excellent papers about showing the evidence base of primary palliative care within the European setting, and we need to replicate that within low middle income settings as well. So thank you to my co-authors Scott and Tanya, and thank you to Tanya for preparing some of the slides. So this editorial really explores how primary palliative care should play an essential role in achieving universal health coverage, emphasising how palliative care can contribute to health services strengthening for the whole of primary care. And this article is open access, so you can get hold of it through that QR code, but I think we'll share the link as well in the chat. So we're all aware of the huge challenge with over 60 million people in the world living and dying with serious health-related suffering, 80% of them living in low middle income countries. And primary palliative care can play a crucial role in relieving this suffering. Many populations are now living longer through improved health, but then non-communicable diseases become more common, and therefore palliative care becomes more urgent. And projections suggest that the need for palliative care may double by 2060, particularly in low middle income countries. And there's serious inequity with palliative care around the world. Many of you are very familiar with this map, showing global opioid use as a proxy for access to palliative care and pain relief. And you note that Africa and Asia, they're very deformed, odd shapes, showing that actually very little morphine is used in these areas. And over the years, international health policy has recognized the importance of primary health care in delivering universal health coverage, and palliative care is also included as an essential aspect of universal health coverage. And so here are a few landmarks on the journey so far. I think a number of folk from palliative medicine, palliative care, so may not be so familiar with the primary healthcare developments. But going back to 1978, the Alma-Ata Declaration, Health for All by the year 2000, the timescale was rather over-optimistic, but health for all through primary healthcare remains a strong concept. And in echoing this, in 2007, the WHO strategy for palliative care introduced the idea of palliative care for all. And then 2014, the World Health Assembly passed a resolution calling member states to provide palliative care as part of comprehensive health services, integrating it into primary health services specifically. And then Astana 2018, 40 years after Alma Ata, reaffirmed the vision of health for all through primary health care. And the United Nations Sustainable Development Goals from 2015, with the idea that they would be achieved by 2030. Goal 3 is good health and well-being, and that includes Goal 3.8, universal health coverage. So this concept is that people should have universal health coverage. It should be high quality, but it shouldn't put them at financial risk, and they should have good, affordable access to medicines and vaccinations. But as you see there, it involves the full range of healthcare, from promotive healthcare to palliative care. Moving on to primary healthcare, this is conceptualized as having 3 complementary components. The first one, integrated health services through primary care and its public health functions. And primary palliative care, as we said, is an essential part of primary care. And the difference between primary care and primary health care is that primary care is about delivery of services to the patient in the clinic. Primary health care is the wider issues, which contains these three aspects. So the second aspect is multi-sectoral policy. So health is one aspect, but also it should coordinate with other aspects such as transport and agriculture, which are essential for healthcare. And then finally, empowered people and communities, recognizing the vital role of civil society, where people have control over their own health provision, and also a role in delivery of healthcare, such as in compassionate communities, and that should be enabled through primary healthcare. And then all of these concepts are interconnected and reinforcing each other to build robust primary healthcare. And WHO remains committed. Dr. Tedros said the world ought to invest in and reorientate health systems towards primary healthcare as the foundation for universal health coverage. Many countries around the world have still got a long way to go to actually establish robust primary healthcare systems, but I think the belief is that universal health coverage can't really happen unless you have robust primary healthcare systems. So primary palliative care really needs to align itself with and embed itself in primary healthcare, such as this conceptual framework. And so from health systems configuration, inputs, service delivery, and then high quality outputs and outcomes. And as primary healthcare develops worldwide, so that universal health coverage can be realized, palliative care needs to co-evolve. Primary palliative care needs to co-evolve with primary health care to make sure that it's really embedded into that conceptual framework. And I mean, this is European webinar, and of course GPs, as we've just heard from those 2 great presentations, have really been involved and continue to be involved in palliative care, and have been really, for the last 60 years, the lifetime of palliative care. And the concept of primary palliative care really gained attention around 2000, and then an article in the BMJ 20 years ago promoted it, encouraging proper funding and research. However, the term has slipped a little bit, and in some publications it's become synonymous with generalist palliative care, and this has caused some confusion. So we decided to, with an international group, look at actually the definition of primary palliative care provided by primary healthcare workers. And we're thinking about why that is important. And this definition, indicates that actually when primary care practitioners practice palliative care, they integrate it into chronic disease management across the whole spectrum. And Scott has already mentioned early identification is a primary care is a place where that can really happen. And then palliative care, or primary palliative care, obviously needs support of specialist palliative care at certain points. But also an important thing is that actually it underlies, it can strengthen underlying professional capabilities in primary care. I'm just going to focus on this just a little bit. We'll just move on because of time, actually. That's SPICT again that Scott has mentioned. So let's look at this framework in a little bit more detail. The framework identifies that high quality primary care is measured by accessibility of first contact, so people able to see their primary care practitioner, continuity, comprehensiveness, and coordination. And these are attributes that were first promoted by Barbara Starfield and colleagues back in the 1990s. Palliative care, primary care really, although it's first contact is the important indicator, the important first step. As we've heard from our other presenters, continuity of care, comprehensiveness, communication are all really important things within primary care, as well as family-centeredness, cultural competency and community orientation. If we look, though, at low middle income countries, we often find that actually skills in this area are often lacking. And actually universal health coverage isn't just a case of actually providing more funding, but actually developing these skills. And if we look at palliative care, that I've highlighted in red, actually palliative care shares these values, these attributes with primary care. And so we have a lot of similarities. And we've also added compassion, because this is becoming increasingly important. It's being promoted by the WHO as being an important bedrock of good universal health coverage. And this conference here was saying, is this the engine for primary palliative care? And so all these things, communication, continuity, compassion, are things which are very important within palliative care. And we've got emerging evidence in the PAL that actually teaching palliative care strengthens the primary care system across its whole spectrum. And so palliative care, there's some concern that actually governments might say, well, should we spend money on palliative care, helping people when they're at the end of life, or in reducing premature death? And actually, like it's a zero-sum game. Well, actually, I think we should say that palliative care actually is health system strengthening, and it can actually improve outcomes across the spectrum. But of course, there are challenges. There's limited understanding, limited training resources, lack of alignment in systems, lack of political will. But we should continue promoting it. And palliative care should really be part of, as I say, primary healthcare development. And since 2022, the EAPC Primary Care Reference Group has been doing seminars like this to promote primary palliative care. We had a meeting in Rotterdam with presenters from Europe, Asia Pacific, Africa, and the Americas, and we're carrying on this this work together. And just so you know, in summary, really, integrating primary palliative care within primary health systems will help us to achieve health for all, palliative care for all, but also health system strengthening and enabling primary care professionals to develop the skills that they need for the whole of healthcare. And prioritising primary palliative care brings us closer to universal health coverage. And palliative care really needs a seat at that developmental table as the primary health care agenda is taken forward. So thank you for listening, and download the editorial, and also let us know what you think. Our email addresses are there, and we'd love to hear from you and join in the discussion. Thank you.
Yeah, thank you very much, Dan. And we can, of course, understand your technical problem at the beginning because you are in Nepal, ne? You are taking this talk from Nepal. That's fantastic. Thank you very much, and thank you very much for these reflections, because they could bring us into the discussion that will be facilitated by Matt.
No, so thank you very much. Do you mind, Dan? I might just take over sharing slides. That's right. Wonderful. Now, of course, we're moving now into the panel discussion. So be really keen to get your thoughts and ask the speakers to share aspects of their presentation which the participants might find interesting. I also just wanted to quickly put a quick advertisement. If you were interested in joining the greater community of the Primary Palliative Care Reference Group, we'd be really keen for your involvement. So have here a QR code, or you can send Nicole, our group convener, also a message as well. Very keen to hear from any of you who might be interested. So I might open the panel discussion. Unfortunately, while I'm sharing the screen, the slides, I can't actually see the chat. I apologise. So I might ask Tanya, if you don't mind, if there were any questions that were popping up in the chat or any hands that were being raised to any of our participants here.
Not yet. We have we don't have questions so far until now.
Okay.
I'm looking here. But the one question was about the relevance of the nursing work in the primary palliative care. Maybe you can position yourself in this in your research. How can you position the nursing work in the primary palliative care? It was one of the questions here in the chat.
Yeah, and that maybe, Scott, you might have some thoughts around that. How that might fit into, the editorial of the future of primary palliative care.
Sorry, yeah, all the research that I've the pleasure of leading with, we've always been in a team, and the nurse has always been a very important part of that, because we know that they actually carry out most of the care in primary care in all countries, I think. And so it's very important to have the insights of that, and then they are there at the very beginning of the research you should be doing. They are independent researchers in many places as well. We know this, the very luminary Catherine Walsh and Julie Downing. There are many, but the place of the role in for the research is great. And I was going to ask actually, what are nursing diagnosis? I don't understand what that means. If someone could explain that, that might just open up the area. Thank you.
Yes. I'm not sure who wrote that comment, but we'd be really interested to hear what the Nanda is.
That was Mina, is it? No, it wasn't. It was.
Nanda nursing diagnosis.
No. Well, if Mina isn't here, I might actually ask maybe Carlos and Micah.
Sorry, there is the acronym of NANDA is North American Nursing Diagnostic Association.
Okay.
Dr. Shani Sequeira sent us the answer.
I might ask Carlos and Micah around the work that you have done with deprescribing and also upskilling primary care professionals to perform palliative care, where you identified there might be roles for nurses in that to strengthen primary palliative care.
I can shortly answer what we have found.
Good.
So identification of patients who would be eligible for deprescribing nurses would be really helpful in having a bigger role in that process. So they see if patients have a sudden decline in functioning and can signal that to GPs and pharmacists to initiate a medication review or even have a greater role in medication reviews and the follow-up of that. So there's definitely a role for nurses there.
Could I comment that for early palliative care, nurses are often have annual reviews. They're the people that are reviewing. So normalizing it thing, especially by a nurse, would be a great way of actually taking it forward. You know, not just at the end of life, but at all times. Great.
Good point. Yeah.
And in my intervention, I think it would be almost mandatory to enroll nurses too. Some of this consultation model could be applied by a first stage approach from nursing. And also, I would like to think about, we missed that improvement in communication, practical issues. And I'm not sure that we missed that because the consultations have limited time. We cannot reach every dimension of suffering, every dimension of the problems that patients may have. And I think to involve another professional that is also in the community, knows that patient and family, almost sometimes since he or she was born or something like that, can actually improve some approach, both in physical, emotional symptoms, but also in practical issues. Nurses can, at least in Portugal, can make some domiciliary consultation, can evaluate the evolution of symptoms. I think it would be mandatory to involve them in this consultation approach.
Yeah.
So could I ask Carlos, sorry, a question about your patients with cancer and heart failure or organ failure? Do you think you could progress it to people with all diagnoses? And did many of your patients actually have comorbidity?
Yeah, I think so. For this study, we tried to have some patients with or without mental dysfunction. So we excluded dementia patients to collect some outcomes using IPOS because we wouldn't be able to collect these outcomes for these patients and compare. But I think they could also benefit a lot, and also patients with multimorbidity as we are talking about this more and more, primary care setting is the place where the multimorbidity grows and develops and starts getting advanced. So yes, I do think that other diagnoses, other kind of patients, even though the frailty, dementia, other advanced diseases should also be included. I don't know if the results will be the same, but I think we should try.
Thank you. It's interesting to speculate. Some of your patients possibly were multimorbid anyway.
Yeah.
That's what we found when we looked at these types of people. Most of them, in fact, were there. So you could be congratulated on caring for that group as well.
Mm. Yeah, you have a question for you, Scott. Question to Professor Scott Murray. You mentioned fragility. Did you mean the clinical fragility scale, CFEs? If so, in Norway, that is a question from Eva. In Norway, we often given too much treatment in the last months and weeks of life. Can CFEs, as a clinical fragility scale, help us make good practical decisions? Not only measure fragility, in other words, can it help us decide what kind of treatment the patient should be given and not? For example, a call can help us to decide if the patient should be given cytostatica or not. Can CFEs do the same thing?
Yes, I think, thank you. I mean, frailty itself is a condition. Again, looking at things like the person is deteriorating, so they may well benefit from more care for holistic care, of course. Clinical scales of frailty index is one way of actually identifying people. And interestingly, most GPs in England actually look for very frail people rather than palliative people, and that they're guided to do that, because often it's the same type of needs that folk have. But the frailty scales and the numbers can be quite helpful. For instance, if they're frail and also have problems with infections or with putting on the clothes, that can be there. Yeah, it's interesting because geriatricians talk a lot about frailty, of course, and that's there without maybe talking so much about dying. But it's the same patients towards the end of life. We should be helping them and not having any silo effect. Thank you.
Mm-hmm. Thank you, Scott.
Yes. And I was interested to maybe bring the discussion around nurses were mentioned, but the larger primary care workforce, and maybe take it to Dan and your experience in Nepal in resource care, poor settings or remote settings, and how other members of the primary care workforce or even informal workforce, such as elders and things like that, might be involved in this larger provision of palliative care.
Okay. So much one could say in this area. I mean, I think just starting with nurses, because I think there are a few questions there I've noticed, and in low middle income countries, I think nurses are often undervalued. I think the concept of a specialist nurse or a nurse with a special interest, special expertise is quite a difficult concept, certainly in Nepal, in our context, and we really do very much emphasize, particularly amongst doctors, that nurses are a very important part of the team, and that nurses will understand things about patients and hear things from patients that doctors will never hear, and if they're not really brought into the team and encouraged and valued, then actually we're not really going to be able to deliver palliative care properly in this context. So very much a champion of developing nursing within palliative care, within primary care in Nepal. We have people called health assistants. They are people who are trained for 2 or 3 years in basic diagnosis and work in village health posts. And actually, we find that they do latch on very quickly to palliative care and are great providers of care within the community. So that's an area that we're developing. And we also have health volunteers, female community health volunteers, who are assigned to a section of the community, of a few families, a few houses, and they particularly work in maternal and child health. But again, we found they're very keen to learn about caring for people with advanced illness, and very much so that are the group link in the patient into the health system. In Nepal, because it's mountainous and quite remote, people can very easily get sequestered away in their houses and not and be quite invisible. But these health volunteers, actually, they identify them and link them in to the health system, and we're just starting to see these things emerge, but it is encouraging. And again, the community volunteers work with the mothers groups in the community, and again, those are groups, because caring is sort of tends to be done by the women in Nepal, particularly daughters-in-law, and they're the ones that go to the mothers groups. So that's a great sort of link in that way. So we're just discovering these things, really, and it is encouraging, but there's a lot of work to do to turn it from a concept into a reality.
Wonderful. Thank you very much, Dan. It's very interesting to hear from all your work in these settings, which I suppose probably isn't familiar to many of the people here. Are there any other questions?
Yeah, we have many questions in the meantime, so we prepare. One maybe related to that you say, Dan and Scott, it was about the compassionate community. Rebecca Lloyd said she worked in compassion communities for some years in Limerick, and it was folded due to the funding issue. When it was funded, it was well received by the community, and we had many successful projects from it. How can we include our communities in palliative care to a point that people keep their autonomy in their dying and care? And in similar, you can maybe say some words about the role of the social worker. It was also asked here. Dan. The social worker was asked by Min Han. Sorry.
Was that Scott who was going to? You asked me.
You Dan. You Dan. You spoke about the compassion community. How can?
Yes, I think compassionate communities in Nepal probably quite different from in Ireland. Just because they're such different sort of places, and I think that actually, compassionate communities really, they've talked a lot about compassionate communities in Kerala and South India, and a lot of people know about those. I think the way that ours work are probably quite different, because the culture is different, and they need to really come from the bottom up, and the communities themselves need to work out how they provide that sort of compassionate care to neighbours and to the wider community. It's a pity this questioner says that it folded due to funding issues, and again, I think that's maybe a lack of political will to actually value this type of thing. My experience in the UK is so out of date now. I'll hand over to Scott to see if he's got.
I'm just going to mention, when I visited Africa and India and seen super compassionate communities working, just as we were saying we should be building on what's happening on the ground in primary healthcare services, similarly on the ground in these countries, there's sometimes a lot of community volunteers or village health workers already looking after the general health of the community, thinking things about very broadly whether they need a bridge or a school or healthcare. So integrating the palliative care, letting them have an understanding so they can add on, thinking about facilitating people being empowered and having autonomy at the end of life, as a questioner was saying as well. So again, building on that rather than thinking, oh, we need a new group for palliative care. Building it into, it's quite difficult. I've tried to speak to such groups, and some say, oh, we don't. That's a difficult one in the West, but in certainly in Africa and India and Kerala, places like that, and Chugoria, Kenya, it works very strongly.
Mm.
And nurses are also very good at doing that. They're highly respected. Moira's paper from the refugee camps there, how much they respected the nurse who knew them, and also the volunteer health workers there. And the refugee workers were very much built into the community. Even in that such poor place, it was the community that was helping.
Yeah, wonderful. So I realise that it is now ticked over to 4:30, and I'm sure there's lots of questions buzzing around in people's heads, but unfortunately we will have to draw things to a close. So I'd like to thank everyone, who certainly the speakers, but also the participants, for contributing the last hour and a half towards delving in further into primary palliative care, both in the European context but also internationally. Yes, so did you want to wrap things up, Tanya?
Yes, well, I want to say something. Most of the message was congratulations to the presenters and congratulations for the research. Also, I joined to this. Thank you for them, for all of you. You present wonderful, very understanding for everybody. And I also add in the chat the link for the special issue. Some of them, I was so engaged with the with the presentations that I forgot to share the link, but I share all the links. Most of the articles in this special issue are open access, and so you can read it more carefully, and you can also reach the author if you have some questions. There are some comments, for example, from Anne, Min Anne of Vietnam. She wants to do research in primary palliative care. Also some comments from Shiny Sequeira, I think, or Shiny John, also interested in to develop this field. Also really very welcome, and join us to have the discussion with you and to support each other into the development of primary palliative care.
Yes, I'd like to encourage everyone to join up. We need nurses, doctors, all types of disciplines in our group, and then we can network together across disciplines and across boundaries and encourage each other, because that's the way to do it. Understand and help in the research and development. So that's my final words. Onwards and upwards. Thank you.
Wonderful words to finish on. So I might draw it to a close, and thank you, everyone, especially our speakers, for their amazing chats, presentations.
Especially attendees, thank you.
All attendees, thank you very much.
Thank you, everyone. I've shared the link